Gastrointestinal bleeding presents overtly as hematemesis, hematochezia, and/or melena. Bleeding may originate from the upper gastrointestinal tract, which includes lesions proximal to the ligament of Treitz, or from the lower gastrointestinal tract. Upper gastrointestinal bleeding typically presents with hematemesis, often described as coffee ground emesis, and melena more commonly than hematochezia. Patients may show signs of hypovolemia, such as elevated blood urea nitrogen, tachycardia, lightheadedness, and hypotension. In contrast, lower gastrointestinal bleeding more often presents with hematochezia rather than melena, though both may occur. Diagnosis of upper gastrointestinal bleeding involves nasogastric tube insertion and lavage, which may be positive in most cases but can be negative in about 15% of upper gastrointestinal bleeds. Endoscopy is the definitive diagnostic tool. For lower gastrointestinal bleeding, ruling out an upper source with nasogastric lavage is essential if bleeding is brisk. In patients under 45 years of age with small volume bleeding, endoscopy or sigmoidoscopy may be used, whereas colonoscopy is indicated if the patient is stable. In unstable patients, arteriography or exploratory laparotomy may be required. The most common etiologies of upper gastrointestinal bleeding include peptic ulcer disease, esophagitis, gastritis, Mallory-Weiss tear, esophageal or gastric varices, gastric antrovascular ectasia, malignancy, and Doliphoi lesions. Lower gastrointestinal bleeding commonly results from diverticulosis, which accounts for about 60% of cases, as well as angiodysplasia, inflammatory bowel disease, hemorrhoids, fissures, neoplasms, and arteriovenous malformations. Initial management for both types of bleeding involves protecting the airway, with intubation if necessary, and establishing 2 large-bore intravenous lines for immediate fluid resuscitation and transfusion when hemoglobin is less than 8 gdl. Transfusion may include packed red blood cells, platelets, or fresh frozen plasma as indicated, keeping in mind that hematocrit may remain normal early in acute blood loss. Once stabilized, upper gastrointestinal bleeding is managed with endoscopy, followed by therapy directed at the underlying cause. Long-term management for lower gastrointestinal bleeding depends on the etiology and may involve endoscopic interventions such as epinephrine injection, cauterization, or clip placement. Intraarterial vasopressin infusion, embolization, or surgical procedures may be required for diverticular disease or angiodysplasia. Upper GI bleeding, esophageal and gastric varices. Esophageal and gastric varices result from increased portal pressure that causes collateral blood flow from the portal to the systemic circulation via portosystemic shunts, leading to dilated esophageal veins prone to bleeding. The most common cause of increased portal pressure is hepatic cirrhosis, typically due to alcohol abuse or viral hepatitis. Other causes include right heart failure and hepatic vein obstruction, such as Budd-Chiari syndrome. History and physical examination. Patients present with painless gastrointestinal bleeding manifesting as hematemesis or melena, and less commonly, hematochezia. They may also show signs of cirrhosis, including jaundice, pruritus, hepatic encephalopathy with altered mental status, asterixis, palmar erythema, caput medusae, and spider angiomas. Diagnosis and treatment. Initial management includes hemodynamic stabilization and transfusion with packed red blood cells, fresh frozen plasma, or platelets as needed. Intravenous proton pump inhibitors are given to reduce rebleeding and transfusion needs for ulcers, and prokinetic agents, such as erythromycin or metoclopramide, improve visualization during endoscopy. For suspected variceal bleeding, treatment includes antibiotic prophylaxis for spontaneous bacterial peritonitis with ceftriaxone and vasoactive agents, such as octreotide. Control of bleeding is achieved by upper gastrointestinal endoscopy, with endoscopic variceal ligation or sclerotherapy, ideally performed within 12 hours to confirm the diagnosis and control hemorrhage. A transjugular intrahepatic portosystemic shunt, TIPS, may be required if endoscopic therapy fails or there is a high risk of rebleeding. Temporary measures, such as esophageal stenting or balloon tamponade, can be used until TIPS is performed. Key fact: although endoscopy confirms the diagnosis, the best initial management step in acute upper gastrointestinal bleeding is hemodynamic stabilization with fluids and transfusion and ensuring airway protection. Other causes of upper GI bleeding. Mallory-Weiss tear. Forced retching causes longitudinal intramural lacerations of the esophagus, resulting in bleeding from the submucosa. Common causes include bulimia, alcohol use disorder, coughing, and hiccups. Diagnosis and treatment are made by upper gastrointestinal endoscopy. Many cases resolve spontaneously, and low-risk patients can be treated as outpatients with fluid resuscitation, antiemetics, and, if necessary, endoscopic hemostasis. Borhave syndrome. This is a full-thickness rupture of the esophagus due to vomiting or straining, caused by increased intraesophageal pressure and decreased intrathoracic pressure. Patients present with retrosternal chest pain and subcutaneous crepitus. Other symptoms may include neck or back pain, upper abdominal pain, hoarseness, dysphagia, or odynophagia. Rapid deterioration occurs within hours, leading to dyspnea, sepsis, and shock. Diagnosis is confirmed with a contrast esophagogram or CT scan. Chest X-ray may reveal mediastinal or peritoneal air, subcutaneous emphysema, pleural effusion, or mediastinal widening, but has low sensitivity. Treatment includes keeping the patient nothing by mouth, intravenous fluids, nutritional support, broad-spectrum antibiotics, and proton pump inhibitors. Free or large perforations in high-risk patients require surgical intervention or esophageal stenting if surgery is contraindicated. Small or contained perforations may be managed non-operatively. Dolifoy lesion. This is an anatomic variant involving a submucosal arteriole in the stomach wall that can rupture and cause significant bleeding. Patients typically present with painless bleeding that may be brisk or self-limited but often recurs. Nonsteroidal anti-inflammatory drug use is a common precipitating factor. Diagnosis is made with esophagogastroduodenoscopy or angiography. Treatment usually involves endoscopic electrocoagulation, though clips or epinephrine injections are also effective.